Hello, this presentation is an introduction session on lung ultrasound in the neonate. This is an overview and this would not replace a full lung ultrasound training. I will start this presentation with some history. Daniel Lichtenstein is an adult intensivist who first described technique, images interpretation, and algorithm of point-of-care lung ultrasound. He is an amazing model of resilience. As he described, in 1986, we had become familiar with the habit of borrowing the machine. It was a night in March, and one of our patients was not well and was not benefiting from our care. It was midnight, and thinking fast, we crept to the radiology department. All was quiet, not a noise. Nobody was there. We unplugged the machine and brought it to the ICU, bed 1. There was supposedly no fluid in the thorax, but actually there was. Action was necessary, there was simply no choice. In spite of the rules, a needle was inserted in the thorax. Amounts of purulent pleural effusion were withdrawn. The obstacle to the venous return decreases. The sign of circulatory failure seemed to improve. The ultimate rendezvous is not for this night. We bring the machine back to the radiology department, clean the fingerprints, we plug it back in. Perhaps on this dark night in 1986, a new standard of care was born. If similar acts were performed in the same setting by some other doctor, we would love to shake his or her hand. Subsequently, Daniel Lichtenstein submitted many articles above the technique description, and all his articles were systematically rejected for the next years. Reason why I think this very, very bright person is quite a good model of resilience as well. There is a massive increase of interest in lung ultrasound in acute settings, reflected by the significant increase in the number of articles on lung ultrasound in PubMed. How can we assess the performance of lung ultrasound? In adults, lung ultrasound has been compared to CT scan, which is the imaging gold standard for the lung. When both imaging techniques were compared in 4 main patterns, which are pleural effusion, consolidation, interstitial syndrome, and pneumothorax, lung ultrasound had an excellent sensitivity and specificity as presented in this slide. In neonates, unfortunately, we do not routinely perform CT scan as such a comparison is impossible. Our only gold standard is a chest X-ray, which is actually a gold standard by default and had never been evaluated in neonates. In view of the large numbers of publications and the need for standardization, international evidence-based recommendations for point-of-care lung ultrasound were published in 2012. Aim was to standardize lung ultrasound application in different clinical settings. It involved 28 experts from 8 countries who met 3 times over 1 year and published 73 recommendations, out of which 65 were in strong agreements. This involved pediatrics and neonatology as well. I have summarized this long document into the following table, comparing the value of chest X-ray and lung ultrasound to rule in, rule out diagnosis of pneumothorax, interstitial lung syndrome, and pleural effusion. Lung ultrasound is superior to chest X-ray to diagnose pneumothorax, interstitial lung syndrome, and pleural effusion. For lung consolidation, lung ultrasound is as performant as chest X-ray, except in ventilated patients where lung ultrasound is more accurate than chest X-ray in detecting and diagnosing various types of consolidation. What about the training? The good news is that it is much simpler than echocardiographic training. This study is a prospective audit of lung ultrasound training. 11 respiratory therapists, unexperienced in lung ultrasound, had first 3 hours of self-study. Pre- and post-study scores were then compared and assessed their image interpretation competency. For practical skills learning, they scanned an average of 15 patients. each and 170 patients in total. The supervisor took over when the respiratory therapist took more than 1 minute to acquire a view. On the left side, you can see that after 12 scans, here, the trainee was competent to perform lung ultrasound. Even after 5 scans, only 10% of respiratory therapy still required practical support. In terms of image interpretation, here on the right, after the self-study, respiratory therapists could properly identify the findings in 93% of cases. After 12 scans, more than 98% of respiratory therapists could interpret properly. We have learned from echocardiography that poor inter-observer agreements could be an important limitation in ultrasound interpretation. This has been studied as well. This is a retrospective analysis which included 114 newborns admitted to the neonatal unit for respiratory distress. Their gestation age was from 25 until 41 weeks and their birth weight from 608 until 4,134 grams. 465 clips were obtained and final diagnosis was compared between 3 levels of expertise: experts, intermediate, and beginner. The beginner was a third-year pediatric resident who had no clinical experience in the neonatal intensive care unit. He was trained by the same lung sonography program as the intermediate, but had never performed lung sonography on his own. And the study shows agreement between the two experts, key one, agreement between one expert and the intermediate, key two, and the agreement between first expert and the beginner, key three. The study shows an excellent agreement between all 3 levels of expertise, 0.81 to 0.9 being perfect agreement. Important benefit of lung ultrasound compared to chest X-ray is the absence of any radiation from this technique. In this unit, lung ultrasound was introduced in 2013. This graph shows the change in radiation per patient admitted to the unit between the pre and the post-implementation period. You can observe a reduction by half of the number of X-ray per baby and a decrease by 3 times the dose received per patient. In total, this resulted in a cost saving of 10,646 euros per year. In adult ICU, same findings have been published. If you compare the pre-implementation period, period 1, with the post-implementation period 4, the mean number here of chest radiograph per patient per ICU stay has been halved. Similarly, the number of chest radiograph per stay, the number of CT scan per stay were significantly reduced and the saving cost was 30,000 euros per year. Which machine should we use? Any machine. In our unit, we have the Philips machine with a long linear probe, L18.5, which we use for term babies. And we have 2 other portable GE machines as well, with a microlinear probe, L1022, which we use for preterm babies. But again, any probe, any machine can be used. You need 3 buttons, switch on button, depth and gain, and that's it. How do we scan? So, if you look at the position of the baby, you will separate the chest in 3 different areas on both sides, and the 3 different areas are defined by the anterior and the posterior axillary line. It's very important to scan the posterior part of the chest, as most of the abnormal signs will be mainly found during the examination of the posterior lung. However, there are some limitations in the lung ultrasound. It needs to be a systematic examination. You need to explore all lung areas as an X-ray, and we cannot assess lung over distension yet. Many people are working on that. So if you want to assess over distension in a baby on HFOV, you need still to request a chest X-ray. So why do we use lung ultrasound when we have been repeatedly told that air is the enemy of ultrasound? Until now, you have been familiar with scanning organs, brain, real images. Today, you will learn about scanning artifacts. Artifacts are created by the principle of propagation of the ultrasound beam. The waves are stopped by air and bones. How to recognize these artifacts is very easy. These are images which are very regular, straight, and geometric shape, usually vertical or horizontal, and more precisely converging to the heads of the probe, like parallels or meridians. So the three main principles of lung ultrasound are first, it is based on the analysis on artifacts created by air fluid ratio. Second, these artifacts are dynamic, so you will record video clips and not frozen images. Third, most lesions are in contact with the surface. Let's start the teaching on scanning the normal lung. First, you need to find the lung. The first artifact you will look for is the pleural line. It is not the pleura itself, but an artifact created by the interaction of the fluid of the subcutaneous tissue and the air in the lung. To find the pleural line, Daniel Lichtenstein has created the bat sign. It is constant, as it helps identifying the lung surface. If you look at the bat here, the upper border of its wings here and the lower part of his body here, the upper and lower rib and the pleural line corresponds to the upper border of the wings and the lower part of the body of the bat. So the body of the bat is the pleural line, the upper border of the wings are the upper rib and the lower rib. And this is the way it appears on your scan: upper rib, lower rib, pleural line. To recapitulate, you need to find first the upper here and the lower rib, and then you can identify the pleural line here. Visualization of the pleural line will always be the first step of your examination. This pleural line should be thin, regular, and most importantly sliding. This reflects the sliding movement of the parietal pleura against the viscera pleura during breathing movements. Absence of sliding is always pathological. This is the way you will put your probe. You put your probe vertically on the chest, the left part of your screen being the head, and the right part of your screen being the foot. Second, you will look for airlines. Airlines means aim in air. These are reverberation artifacts of the pleural line and appeared as horizontal and static. They are positioned equidistant. They are physiological and mean there is air. You can see here horizontal, parallel, static, and same distance. This is an ultrasound video clip of a normal lung. You can see the thin, regular pleural line sliding. Here the upper and the lower rib. And here you can see the air lines. The first scan is transversal and the second scan is longitudinal. We are scanning here between two ribs, reason why we cannot see them. Third, you need to look for B lines. B lines are hydroaeric artifacts indicating fluid-air interface. As you can see, it is actually made of multiple small horizontal lines. I don't have time to go through full explanation, but these very small multiple horizontal lines are called J lines. B lines have characteristic features. B lines arise from the pleural line. They move with lung sliding. They are well defined. You can see them until the end of the screen. It is long, spreading out without fading. It obliterates the A-line and it is hyperechoic. And it correlates with lung fluid content. Alveolo-interstitial syndrome is defined by the presence of 3 or more B lines between two ribs. We can call them lung rockets. And there are different types of lung rockets depending on their abundance, and they are well correlated with CT scan appearance. Here you can see here septa lung rockets, well separated, and here this is ground glass lung rockets. They are correlated with the severity of alveolo-interstitial syndrome. Again, you have the ribs here, the pleural line. You can see some A-line, and you see this hyperechoic vertical artifact that arise from the pleural line, are dynamic and spread all along your screen without fading. C for consolidation. Daniel Lichtenstein has created the full alphabet, but we will stop after consolidation. Consolidation is a fluid disorder providing an hypoechoic image with tissue organ appearance. The pleural line is not visible, hardly visible, maybe here, but not well visible. Consolidations erase air lines and contain some air-trapped NEM air bronchograms that can be static or dynamic. You see this point is not moving, the air is trapped, it's a static bronchogram. Here the air is moving up and down. This is what we call dynamic bronchogram. Lung ultrasound can differentiate consolidations due to embolism, pneumonia, or atelectasis. To finish with the description of the main patterns, pleural effusion. It appears usually as an echoic area between visceral and parietal pleura. To discriminate between pleural effusion and atelectasis, you may need to put an M mode that will show you the sinusoidal sign reflecting the movement of the visceral pleura with breathing movements. Here, we have put an M mode on the lung and on the diaphragm, and you can see this sinusoidal sign reflecting the breathing movements. In adults and pediatrics, you can even quantify the amount of fluids. In neonates, it can inform you about the level of fluid effusion, guide your needle or drainage, and monitor your treatment. To summarize, all artifacts, you see artifact when you have more than 10% air. All of here, this part is artifacts. And real images seen when there is less than 10% air. And all these artifacts and real images can be described on the scale of air fluid ratio from 100% of air to 0% of air. 100% of air being pneumothorax and 0% being effusion. In between, you have A lines, you have B lines, you have consolidation of various etiologies. If we move to the neonatal lung, all ultrasound signs described before can be found in the newborn. In addition, and this is helpful for us, the neonatal lung is very fluid rich. The newborn lung is echogenic. It's a small thorax, so it's fast to explore entirely. We are looking for specific disease. And lung ultrasound protects the newborn who is still in developmental stage from radiation. I have chosen to talk to you today about 3 main frequent neonatal lung pathology, and I will then list other possible scenarios of pathology where lung ultrasound is now playing an important role. First, pneumothorax. In a pneumothorax, the visceral and the parietal pleura are separated. Then, if they are separate, the lung sliding will disappear. All you can see here will be air. So you will have A lines. But as there is no lung parenchyma, you cannot see any B line, and this is extremely rare in the neonatal lung. As a consequence, the main 3 criteria you need to remember today for diagnosing pneumothorax are absence of lung sliding, absence of B lines, presence of A lines only, and presence of a lung point. Sorry, there were 4 points. Presence of the lung points. And the lung point is the point where both pleura are separated. If I go on the previous slide, this is this point that we call the lung point, and you will systematically need to find this lung point to confirm the diagnosis with 100% sensitivity and specificity. This is an example of a pneumothorax. You can see here the pleural line is not sliding, when here it is sliding. You can see the difference. There is only A line here, here, and here. And there's no B line here, whereas you have a lot here. And you can see that you have a separation here between this part of the lung that is sliding. This one is not sliding. This is your lung point. Again, some more images in this baby who had... On the right slide, you can see the lung is shared into 2 parts. On the left side, the pleural line, you can see a regular line, A line, no B line, and this pleural line is not sliding. On the right side, you have a different lung. You have a shredded pleural line that is sliding. You have vertical B lines, coalescent B line that erase the A line. And the junction between these 2 parts are the lung point. All of these criteria are level A of evidence from VMP international recommendation. To summarize the evidence on the lung ultrasound, it can be used in clinical settings when pneumothorax is in differential diagnosis, meaning critical care and emergencies. Lung ultrasound more accurately rules in and rules out the diagnosis of pneumothorax than supine anterior chest radiography. And lung ultrasound is a useful tool to differentiate between small and large pneumothorax using detection of the lung point. I will just show you one publication on pneumothorax and lung ultrasound in the neonate. This is the LUS trial, which is a multi-center international study, including crashing neonates with well-defined inclusion criteria. objective was to compare lung ultrasound and chest X-ray to rule in or rule out pneumothorax. 26 out of 42 crashing neonates had a pneumothorax. Lung ultrasound was done and results obtained in 5 minutes, while it took 19 minutes for the chest X-ray. Of course, the main pathology in neonates is respiratory distress, and lung ultrasound can support your clinical examination and investigation for the diagnosis of the cause of your respiratory distress. It can help you to diagnose pneumothorax, as we just discussed, respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration syndrome, congenital diaphragmatic hernia, congenital pneumonia, pulmonary hemorrhage, and pulmonary malformation. Today, in view of the limited amount of time we have, I will only talk about RDS and TTN. RDS is really well defined. It's defined by a very thick pleural line with here some subpleural consolidation, diffuse coalescent B lines giving aspects of white lungs, and there are no spare areas. On the other hand, TTN is characterized by a normal pleural line, bilateral coalescent B lines in inferior areas. This is why it's important that you orientate your videos properly, head on the left, foot on the right. So white lungs in the inferior areas, and near normal or normal appearance of the lung in the superior fields. This is what we call double lung. You have two different lung points, double lung point. Double lung point has been studied in a prospective study including newborns admitted to the neonatal unit for respiratory distress diagnosed as TTN. This is the attention protocol. What the authors found is that they found the double lung point in 47% of their cases only. They found no consolidation with a diameter more than 0.5 centimeter, a regular pleural line, and the lung ultrasound correlated with the severity of the respiratory distress. As you can see, these double lung points may be missed early on. I mean, only 39% of the double lung point are present in total on the first 24 hours, and the late double lung points appear after 24 hours, and 9% of the case appeared after 24 hours. To summarize, RDS is characterized by pleural line abnormalities, airline disappearance and or bilateral white lung consolidation with bronchograms. TTN is frequently 50% of the cases associated with double lung point. It means bilateral confluent B line in inferior areas, and near normal or normal appearance of the lung in superior fields, and most importantly, a normal pleural line and lung sliding. The evidence from the International Evidence-Based Recommendation in 2012 reported that lung ultrasound is a clinically useful diagnosis tool in neonates with suspected RDS, TTN, and pneumonia. It is as accurate as chest X-ray in the diagnosis of RDS, as accurate as chest X-ray in the diagnosis of TTN, and as accurate as chest X-ray in the diagnosis of pneumonia in pediatrics. Now, could neonatal lung ultrasound monitor fluid clearance and predict the needs of respiratory support? In the current European guideline, it is recommended to provide surfactant early but electively. Objective of the following study was to evaluate if lung ultrasound was correlated with oxygenation scores and could predict need for surfactant. Authors created a score based on the assessment of 6 lung regions. Each region had a score of 0 if the lung looked normal, 1 if you have lung rockets, 2 if lungs were white, and 3 if you could see consolidation. They presented a prospective monocentric study including 130 neonates with respiratory distress syndrome from 27 to 41 weeks, and they assessed the transcutaneous PO2 over FiO2, alveolo-arterial gradient, alveolo-alveolar ratio, and oxygenation index. And they first assessed correlation between their lung score and markers of oxygenation, and second evaluated if the score would predict surfactant administration. They found that lung ultrasound correlated significantly with oxygenation indexes, PCO2 over FiO2, alveolar arterial gradient, oxygenation index, and arterial alveolar ratio. Regarding surfactant administration, lung ultrasound predicted well the need for surfactant in the cohort of less than 34 weeks. So near term, the predictive value of lung ultrasound to predict the need for surfactant administration is not really good. As the most at-risk population is the extreme preterm neonates, the authors looked more specifically into this population. And in this study, they included 133 newborns having RDS treated by CPAP, and they administered surfactant based on European guidelines. And they compared lung ultrasound on admission and before retreatment. With a score above 6 to 8 and mainly 8 for first surfactant administration, the score was highly predictive of surfactant administration. However, the score was not predictive for the second dose of surfactant with a post-test probability of 31% only. So these authors have shown that lung ultrasound would predict the need for surfactant in preterms less than 30 weeks, and it has been shown that delayed administration of surfactant after 3 hours after birth would increase chronic lung disease. So they subsequently looked as part of the QI project if performing lung ultrasound would allow to increase the number of babies receiving surfactant in the first 3 hours of life. And they compared 2 periods of time, a standard period when they strictly followed the European guideline, and the implementation period when they used both lung ultrasound and European guideline, whichever came first. Both populations were comparable. And you can see on the left side of the slide the maximum, the percentage of neonate receiving surfactant within the first 3 hours of life. On the right side, the maximum FiO2 on both populations, the standard period when the European guidelines were applied, and the second period of time that was European guideline plus lung ultrasound score. And you can see that the percentage of neonate receiving surfactants within the first 3 hours of life was significantly lower in the second period when lung ultrasound was applied. And the same was observed for the maximum FiO2. On the second graph on the right, you can see here 2 periods. Your first standard period, lung ultrasound plus European guideline period on the right side. 120 and 180 minutes are the optimal time to deliver surfactant, and you can see that above 180 minutes after 3 hours, the number of red arrows reflecting the number of patients who received surfactant after 3 hours. This number was much more important during the standard period versus the implementation period of time. Other indications where lung ultrasound can be useful in your management are endotracheal tube position, chest drain insertion and removal, diaphragm assessment, ventilatory management, including lung recruitment, fluid management, crushing neonates, and early management of the extreme preterm, especially during the golden hour. This is an example of a case we had in the unit, a baby born at 24 weeks, and you know that very small movement of the ET tube can be very badly tolerated. This baby on day 1 had surfactant 2 hours ago, and lines were in, and after the lines were inserted, baby became mottled with a respiratory acidosis. And when I checked the ET position, I could see that the tip of the ET tube was at the level of the aorta, meaning it was absolutely far too low. So we pulled the tube by 0.5 centimeter for a total length of 1 centimeter, and the baby immediately improved. Just of a notice that we could really well assess your diaphragm first to see if the diaphragm is moving on a patient that have spontaneous respiratory movement on the mid-clavicular line with a semi-convex probe, low frequency, and a notch at 12. And you will examine mainly the posterior diaphragm. And you can assess here the contractility of the diaphragm with the index of thickening by a mid-axillary linear high-frequency probe, notch at 12, and then between ribs. This is the mid-clavicular, the very much easier approach here. You use the lever as an acoustic window and you study the posterior diaphragm, and with a normal breathing subcostal approach, you can see here the sinusoidal sign. This is a diaphragm that is working well. Just you to know, there are multiple publications about the endotracheal tube position assessment using ultrasound in neonates, and this is absolutely feasible but needs a bit more training. And finally, there are now more and more algorithms being developed. It's been used extensively already in adults and pediatrics, and with Nadia Youssef, we developed this algorithm named the SAFE protocol. It's a very simple algorithm that allows you in less than 2 minutes to exclude all neonatal emergencies. Here we have the SAFE protocol, and we've just presented at the last launch the SAFER protocol, which includes the full body. So to summarize, lung ultrasound is a quick exam with an average duration of 2.5 minutes once you are experienced. It's very accessible because we all have ultrasound machine already in our NICUs. It is radiation free. You can do it bedside, 4 dimension. You can do it real time, monitor the response of your treatment, your ventilation, especially in life-threatening situation. It's very cost effective with a steep learning curve, and there's a very strong agreement between observers. This is the curriculum we worked on with Nadia Youssef in France with a world expert in the neonatal lung ultrasound. So you can go through this curriculum, and if you're interested, you just come and see me and we can work on that. Francesco Remandi is the father with Nadia Youssef of the lung ultrasound in the neonates. Initially, we were on only 7 countries being represented, and now it's more than 200 people joining the LUS group on Facebook. So once you're trained, you will be welcome to join this group of experts where you will have all the latest updates. Thank you. Enjoy, not too much, and have a good training.